Good morning. This is Dana Parsons. Thank you all so much for joining us today, especially at this different time. We appreciate that. We'll be back on track next week, June 10th at 11 a.m. Next week is really going to be focused on reopening and testing, so we hope that you will join that call as well. Kelly Parker, have you joined us? Or Matthew Mary from the Virginia Hospital and Healthcare Association?
Good morning, Dana. Can you hear me? This is Kelly.
Yes, thanks for joining us, Kelly.
Sure.
Over to
I
you.
will go. Thank you very much. Just provide a brief update on some of the numbers that we are seeing. Obviously, our hospital numbers are being used as metrics from the state in terms of reopening impacts. As of this morning, we have seen 1,311 confirmed and pending hospitalizations. 313 of those are in the ICU, and 185 of those is on ventilators. That includes a reported 876 confirmed hospitalization, which is a 4% decrease from the previous day. We are monitoring that regionally as well to see that there are certain regions that might have a slight increase and certain regions that have a slight decrease in hospitalizations. However, overall, from the state perspective, we do see a downward trend in COVID hospitalizations. From the long-term care facility side, skilled nursing facilities specifically through our VHOS reports, as of today, we have a total of 1,676 confirmed and pending cases within long-term care facilities. This is 1,280 confirmed positive COVID-19 residents and 396 pending COVID-19 residents. We do have 16 distinct facilities that are reporting difficulties obtaining PPE in the next 72 hours. And that varies between face shields and N95 gloves, isolation gowns, et cetera. And that can includes an 88% response rate from the VHOS alerts that were sent yesterday. And that is all I have, Dana. Happy to answer any questions.
Thank you. Do we have any questions for Kelly?
Not at this time, Dana.
Okay, thank you so much, Kelly. We appreciate it. At this time, I'd like to over to Sara Lineberger. Have you joined us?
Hi, can you hear me?
Yes, thanks so much, Sara. Over to you.
Okay, great. Thank you. Good morning, everyone. We have several things we want to share with you this morning. Just a quick update on numbers. As of today, we have almost 47,000 cases of coronavirus in Virginia, and we have 375 outbreaks. We continue to see outbreaks trickle in. 217 of those are in long-term care facilities, which again is skilled nursing facilities, assisted living facilities, and group homes. And so that accounts for about 58% of all outbreaks. So that's sort of holding steady. I do want to mention, I know many of you have been doing point prevalence surveys, and we continue to welcome any feedback on that, including working with the National Guard. I think overall it's going well, although scheduling, is always a challenge to get all the pieces lined up. So if for some reason you haven't been able to schedule and you would like to, you can always reach out to me and I'll connect with our testing team. One thing that I want to mention is that when the National Guard comes on site to conduct these point prevalence surveys, they're also able at the same time to train newer staff on how to collect NP swabs. And we would really encourage you to take advantage of doing that and ask that the National Guard do that while they're at your facility, because we would like nursing home staff to be trained on how to do that so that nursing home staff can help with testing moving forward. So just wanted to mention that in case that hadn't been shared, that the training for your staff on doing NP swabs is something the National Guard can help with while they're on site. We also want to mention, I know you all have been working hard to get into Nhsn and start sharing data for COVID in the long-term care module, especially our nursing homes. And so I did want to mention that we also need you all to confer rights to VDH so that we can see the data. And I have Virgie Fields on the phone. She's our HAI epidemiologist and manages all of the Nhsn data for the state. And she was just going to mention a few things and also share the instructions with you all on how to do that. Virgie?
Yeah, good morning. Can you hear me?
Yeah.
Great. Yeah, so as Sara mentioned, I'm the HI epidemiologist at LeadingAge, and I've been working on analyzing our Nhsn data from healthcare facilities. So LeadingAge currently does not have access to any long-term care facilities data in Nhsn. In order for us to view that data from facilities reporting in Nhsn, each facility has to join our LeadingAge Nhsn group. We're thinking of using these data in our phased nursing home reopening guidance, which we'll talk about, I guess, next week or share soon. So it'll be necessary for facilities to share their data with us. We have posted our instructions on how to join our group on the Virginia Long-Term Care Task Force page. I'll include the link for the instructions in the chat box in a second. It's a simple process that shouldn't take more than 5 minutes, and it has to be done by the person in Nhsn for each facility that is the facility administrator or who has administrator rights. And so I'll post the link to the instructions, but we also plan to post and distribute a memo with this information to our partners soon. But facilities can start joining our Nhsn group now. But if you have any questions, feel free to email our HEI@vdh.virginia.gov inbox.
Thanks, Virgie. In general, all of us are new to the COVID module in Nhsn, but just to let you all know, we have been working with the Nhsn system for at least a decade now and working with hospitals routinely report data into that system. So if you do have Nhsn questions or having trouble with Nhsn, we can also be a point of contact for you. And thanks to Virgie for leading all that work here on behalf of our team at VDH. So like Virgie mentioned, Dana, we will be sharing sort of a memo that outlines sharing the data, but the instructions are already posted on the website, and Virgie shared those.
Thank you. We'll definitely include those in our update today. Thank you.
Okay, that's great. Thank you. And then the other thing I wanted to mention is we've been working really hard on the reopening guidance for nursing homes, and we're hoping that that's released potentially by the end of this week. We have in that reopening guidance checklist by phase for nursing homes to sort of check off. And there will be ways that you can communicate with your local health department on which phase you're in and what you've been able to accomplish and what you may need help with. And so we are aiming for most facilities to be able to try to go ahead and move into phase 1. And some of the criteria that need to be met you can accomplish while you're in phase 1. So we're sort of aiming, instead of having a pre-phase like CMS, we're aiming for all facilities to hopefully be able to soon move into phase 1 and then accomplish some of the things in phase 1 if you haven't already, like if you haven't been able to do baseline testing yet, that can be accomplished while you're in phase 1. Same thing if you haven't had any sort of infection control assessment or survey, that won't hold you back from starting phase 1, but could be accomplished in phase 1. And so we're really excited to share all that guidance with you. We're just trying to finalize some of the details and sign off on that. And excuse me, I think, Dana, that's all I have right now, unless there are questions.
One question that came in, Sara, is can assisted living staff participate in the National Guard training?
Yes, if the National Guard's at your assisted living facility, by all means, or or at a facility with assisted living staff, yes, by all means. That's not limited just to nursing homes.
And then another question that came in is if there is contradictory advice, recommendations, or policies between CMS, OLC, and the health department, what are licensed nursing facilities to do?
That's a great question. So the CMS recommendations essentially charge states with figuring out how to implement all their recommendations in the state. And so we're taking the CMS guidance and sort of trying to figure out how to operationalize it statewide and what the details look like. And I'm in the Office of Epidemiology at LeadingAge, and we are working closely with the Office of Licensure and Certification on this reopening guidance. And so OLC is part of these discussions, and we'll be putting this out jointly.
Great, thank you. No more questions have come in for Sara so far.
Sara, I would like to revisit the training opportunities through the National Guard. So is there a formal process that once they're there or prior to them getting there that a community would need to do to request the training? How is that being handled?
Yeah, that's a great question. I don't think that there's a formal process. I think that if you are scheduling, so the National Guard teams who are coming on site to do PPS, to do a point prevalence survey, have the ability to train staff at the same time. So my only recommendation is that when you're scheduling a point prevalence survey, to just mention that you would also like your staff to be trained at the same time.
Okay, great.
But there's no other like request or paperwork or anything that needs to happen. I would just mention it when you're scheduling your point prevalence survey.
Okay, well,
and we
thank
do,
you.
Sorry, Janet. We do have National Guard teams also going out and doing fit testing with nursing homes and assisted living facilities. And so if that's something you're interested in, we're also trying to work towards more staff in these centers being fit tested. And so certainly reach out to your local health department or to us if you would like fit testing for your facility as well. Many facilities have already done that through the National Guard.
Okay, great. So just to recap, they can reach out to the local departments of health, but they can also, when they request the other training with the National Guard, they could also request fit training at the same time.
Yeah, I'm not sure. Yes, I think that's correct. I'm not sure if a facility would want fit testing and a baseline point prevalence survey test all on the same day. That's going to be a lot for your staff. But definitely when you're having those conversations with the National Guard, if you want fit testing, mention that too. And I think the scheduling details can be worked out. And we are, Dana, like I mentioned on in another conversation we had this week, we will likely send out a list to you and just ask for feedback from your members on which facilities have been able to do fit testing and which still need fit testing, because we're looking at other resources to pull in to support fit testing as well.
Sara, another question came in, which is, do you have to have positive cases before doing a point prevalence survey?
No. We're trying to do testing in all facilities. We certainly have been trying to prioritize those with outbreaks, but we're moving forward with trying to do baseline testing in all nursing homes.
And Sara, before we let you go, do you have any updates regarding the FEMA PPE distributions?
I do not. I don't know if Kelly's still on the phone, if she would have updates. I'm not the PPE expert in terms of distribution.
Okay.
I can definitely take that question back if Kelly's not still on the phone.
Okay, well, you and I can talk about that offline, and then we can include any updates in our daily update that we send out. Are there any other questions, Melissa?
Not at this time.
Well, thank you, Sarah, so much for the update. We really do appreciate your support. Thank you so much, and especially for the different time today and making that work.
Oh, sure. Thanks.
So CMS announced some enhanced survey activity and enforcement remedies related to infection control. So we are very fortunate to have Jody Igor, the Director of Nursing Home Quality and Policy with LeadingAge National, to really focus for the remainder of our call on this. So thank you, Jody, for joining us, and over to you.
Thanks for having me. So, yes, it has been an exciting week. CMS released on Monday evening a new memo, QSO 2031 All, and this outlines new expectations for surveys as well as new enforcement remedies. So, before July 31st, CMS's expectation is that 100% of nursing homes in every state will receive an infection control survey. About 53% of nursing homes have been surveyed already across the country, and it varies from state to state. I think CMS said that some states had completed 11%, others had completed more than 50%, but CMS is incentivizing the state survey agencies by threatening to withhold CARES Act funding. You all might remember that when the CARES Act came through, it allotted some more funding for state survey agencies to be able to complete these surveys. If the state survey agency is unable to meet the requirements that CMS has put forth for infection control surveys, then the state survey agency has an opportunity for a corrective action plan. And if they're still not able to complete, then within a certain amount of time, they would begin to lose some of that CARES Act funding. So in addition to this 100% of all nursing homes receiving infection control surveys, CMS says that on-site surveys need to be completed by the end of June. It was within 30 days of the memo for nursing homes that have cumulative cases of COVID-19 that are at 10% or greater of the bed capacity, cumulative and confirmed cases that are, cumulative suspected and confirmed cases at 20% of the bed capacity or greater, or nursing homes that have had 10 or more deaths related to COVID-19. And also, on-site surveys within 3 to 5 days of identifying 3 or more new cases or 1 case in a facility that was previously COVID-free. And the way that this will be identified is through that Nhsn reporting that we are required to do. And then also in fiscal year 2021, so going forward indefinitely, infection control surveys need to be completed on an annual basis for at least 20% of nursing homes in the state. CMS has also put out some recommendations for how survey activity would be reintegrated. We saw that first whenever they released the reopening nursing homes guidelines, and they talked about it a little bit more in this memo. Your standard surveys, as you know, are coming back in phase 3. Complaints and facility reported incidents are coming back in phase 2 for those that are G level or higher. Also, your IJ revisits, those continue, and your special focus facility and special focus facility candidate surveys will be prioritized along with your infection control surveys whenever the standard surveys are reintegrated. For the complaints and facility reported incidents, that priority has not changed. It would be abuse and neglect complaints or facility reported incidents, those related to infection control, violations of transfer and discharge rights, any issues with staffing and competency, and then of course quality of care issues like pressure ulcers or falls. In addition to all of that survey activity, there are also enhanced enforcements. And so for anybody, first of all, everyone expect an infection control survey. And for anyone who receives an infection control citation, if it is at D level or higher, you will receive an enforcement remedy. Your enforcement remedy will depend upon both the scope and severity of the citation, the current citation, but then also your past history of noncompliance in infection control and prevention. So for example, if you have a D level infection control citation on your current survey, but you have no history of noncompliance in infection control for the past year or on your most recent standard survey, the enforcement remedy would be a directed plan of correction. But those enforcement remedies increase and include a combination of directed plans of correction, discretionary denials of payment for new admissions, and the opportunity for correction for those discretionary adopters ranged from 45 days to correct down to 15 days to correct. And also per instance civil money penalties that range from $5,000 all the way up to $20,000 depending on the severity. So I mentioned the D level citation with a history, with no history of noncompliance. Another example would be if you had a F level citation, you've had citations, any citations in infection control in the past 2 years or on your 2 most recent standard surveys, those enforcement remedies would be a directed plan of correction, a discretionary adoption with 30 days to correct, and a $20,000 per instance CMP. So you can see how these things range and how these things intensify. In addition to all of that, CMS does point out that they have refocused the work of the QIOs, your quality improvement organizations, to assist with infection control. In some places, the QIOs are focused to be working with smaller nursing homes, rural nursing homes. In other places, they're focused to be working with nursing homes that have lower star ratings or have a history of issues in certain ways, but also your state could request assistance. And this targeted assistance could be helping the nursing homes walk through a not a plan of correction, but you identify the issue, kind of like your QAPI plan, right? You identify the issue, you go through your root cause analysis, and then you identify ways to solve it. They can also help with training on proper donning and doffing of PPE, things like that. In addition to all of that, the QIOs do host a weekly infection prevention and control training. This is on Thursdays at 4 p.m. Eastern time. So it runs into the LeadingAge national call, but it's very, very worth your time to go to an infection control training. So we'll forgive you if you jump off our call a little bit early for that. But we have concerns, of course, we have concerns with all of this because infection control is really important, and we really need to be doing everything that we can to improve infection control in nursing homes. That was true before COVID. It is especially true now that COVID is so prevalent. You know, if I heard someone say yesterday, if it's not in your home yet, it's going to be there, right? So, of course, infection control is important. And we understand that survey is one of the ways that infection control issues are identified and addressed. We've always been concerned about the strategy of taking away the money that people need to do their jobs, because how then are you supposed to do your job? And now that is also being applied to our state survey agencies, which we know in some states across the country that they were already short-staffed and having difficulty. And so it'll be interesting to see how all of this plays out. Of course, LeadingAge is always going to be advocating to make sure that nursing homes have the support that they need, that they are getting the assistance that they need, and that they are, you know, acting to the highest level of quality and to the highest standards. So that's all still unfolding, and we're working on it, but never fear, LeadingAge has got your back. And I'm happy to take any questions.
Wow, Jody, I don't know how you keep it all straight, but thank you for keeping it straight for us. I've got one question that came in regarding the Nhsn masks. They are not PPE, but since they were sent as PPE, will facilities be tagged for calling them and using them as PPE?
So yeah, it's it's really interesting. PPE is something that a lot of reopening hinges around. It's something that is inherent in the surveying. It's important for infection control, and that is what's being sent out. We're hearing of cloth masks being sent out everywhere, and we know that cloth masks are not the recommended PPE. CMS had said a while back that facilities would not be cited for not having appropriate PPE as long as they could document all of the actions that they had taken to try and get appropriate PPE. They have not rescinded that statement. They have not withdrawn that recommendation. I would also recommend looking at the CDC guidance on optimizing PPE strategies. Always be reevaluating whatever strategy you're using. Use the CDC's burn rate calculator. Everything that you can do, all of the backup and all the documentation that you can have to show that the decisions that you're making are made with of course, the best intentions, but that they're also, it's an educated decision that you're making. It is a thoughtful and planned out decision, and that you are working on a plan to step up the PPE or to step up the infection control as soon as you are actually able to do so. I think all of those things will go a long way.
Thanks, Jody. I don't have any more questions right now in the chat box, Dana.
I wanted to, I'm sorry, go ahead.
Sorry, can I add one thing?
Yes, please.
This had come up a few weeks ago somewhere. I don't remember what call I was on, but there was a question about the Nhsn reporting about PPE. And if you guys recall, when you are reporting, it asks about your current supplies of PPE and if you have enough for, I think, the next week or something like that. And CDC had said, if you are operating on crisis level strategies for PPE usage, or if you're even operating on contingency level PPE strategies, that is not recommended PPE. Of course, that's not the conventional level. And so you can reflect that in your Nhsn reporting. Just because you're making it work with the cloth masks, or just because you're making it work with some other type of PPE that's not necessarily the recommended PPE, that doesn't mean you have it. And so you can report that on Nhsn accordingly. And now we see what a challenge that is, right? Because on the one hand, you have to do accurate reporting or you're going to get penalized for that. And then on the other hand, it's a little wary to do the accurate reporting because you're going to be targeted. But if we are reporting accurately, that's the best way for CDC to know what's going on, for CMS to know what's going on. And that's the best way to say, hey, listen, we have a problem with PPE.
Jody, another question came in and says, if a community has no cases, do they have to wear surgical masks or KN95, or are cloth masks still acceptable?
So I think what CMS, I'm trying to dig back through my brain, so I apologize. I believe CMS had said all recommended PPE if there's any cases in the facility. And I think what CDC had said was cases in the facility or widespread community transmission that you needed to be using the recommended PPE. And if not, or if you were not in a direct care situation, then the cloth masks would be acceptable. So when the surgical masks come into play there, I think that one's a little bit more difficult because a surgical mask provides better protection than a cloth mask does. So if you have no cases in the facility and you're providing care, I don't know that you would be required to use an N95, but a surgical mask might be better than a cloth mask. Probably check, number one, with your state or local health department, but then also refer to CDC guidance on that. That was my long talking it out explanation.
Thank you, Jody. That's really helpful. Thanks so much.
Jody, we had another question come in to clarify if the state is or is not requiring non-Medicare certified nursing homes to enter data into the Nhsn database. That's voluntarily, right, for non-certified communities?
Yep. So if you're a non-certified nursing home or if you're in assisted living, because CDC is also asking for that, CDC wants as much information as they can get, but the CMS requirement only applies to the CMS certified nursing homes and then any requirements that the state of Virginia would otherwise place. So, so it's a good thing to check and make sure that Virginia is not requiring the licensed but non-certified nursing homes to report or assisted livings to report. But CMS's rule only applies to certified nursing homes.
Yeah, and that's my understanding of what Virginia is requiring. Do you have any cautions or concerns if a community voluntarily wants to report? Um, are there any concerns about a non-certified community doing that? Do you think it would prompt any issues for them, or is it just generally encouraged?
Isn't that a loaded question?
Sorry.
No, it's quite all right. It is the world we live in, right? So, yeah, I think that I think on the one hand, it's very, very good to put information out there so that CDC knows and so that we can all work together to try and address this issue, to try and combat this virus and to inform us as we look to the future and try to prevent the resurgence in the fall or to be better equipped for the resurgence in the fall. On the other hand, CMS has very plainly stated that they will be looking to that NHSN data and they will be utilizing that data to help guide their survey activity. And so, so yes, you do open yourself up. I think you do make yourself vulnerable by reporting into NHSN because if there are 3 or more new cases identified, or if there's 1 case in the facility that was previously COVID-free, you have made yourself vulnerable in that way, but your fail-safe is then, of course, how you are operating your infection control program. And if you are doing your infection control, and that is also a very loaded statement, and I recognize that. The other thing to remember is that if you are not CMS certified, then you don't have that CMS certification number. And so CMS will not be pulling that data because they're pulling by CCN, but your states do still have access to the NHSN data, and so there could be an interplay there.
Yeah, okay. Well, I appreciate your thoughts on that. I
Hey,
wanted
this
to
is
mention,
Sarah.
yes,
Hey, this is Sarah. Can I just weigh in on that?
yes, please.
I don't know if Virgie's still on the phone and she can correct me if I'm wrong, but I think what you just stated is correct. Typically, and I'm assuming this is what we're doing for the COVID module, any data voluntarily reported to NHSN is seen by CDC and could also, like you're saying, be seen by the state health department if the rights are conferred by the facility. But if it's not data required by CMS, that data is not going to be shared with CMS. So the way NHSN works is NHSN is this big national electronic system. It's managed by CDC. CDC has all the EPIs doing all the data analysis and running the system, and then they send these big files to CMS so CMS can see the data. So they're sort of doing it on behalf of CMS. But typically the state health departments and CDC are using the data as much as we can for action. And if it's data voluntarily reported, and a lot of the hospitals do report for healthcare associated infections more data than is required by CMS because they use it internally to track data as well. Any data not required by CMS isn't going to go to CMS. So I don't know if that helps.
It does. Thank you. Thank you, Sarah. We appreciate that clarification. I wanted to mention that in our update today, Jody has done a great article about the new enhanced survey activity enforcement remedy. So be sure to check out our update that will be included today. Before we end our call, we may be able to end a little early today. I just wanted to give another opportunity for any more questions for Sarah or Jody. Okay, well, great. So we'll be ending a little early today. I appreciate everybody being on. We'll be back on track next week at 11 a.m. And testing and reopening will be the focus of that. So thanks to everyone and have a great rest of your week.